population and biomechanics, which is, yeah, that's
Okay,
actually
week
super
5
interesting.
assessments. Here we go. I'm going to demonstrate each assessment on, I'll probably use Trevor, and then we'll do it on the actual skeleton, Phil. And we're going to go through everything today just to get a broad picture of each individual assessment. But my plan for the review session is for us to go through all of the assessments together as a group. In a live setting, I'll pick out people individually, be like, hey, this is a good example of this. We'll go through all of them. And then as this course progresses, as we get through, the next couple of review sessions, we'll actually start doing live assessment and intervention. We're going to go over what each test is exactly testing for, understand what the expected measurements are for the normal, quote unquote, asymmetrical pattern, and finally understand the importance of test and retest protocols. Why do we care about these tests in the first place? Well, one, they're going to tell us what's going on locally and systemically, but also they are our retest measurements. What's really cool about these assessments is that they're not going to lie to you. If you do an intervention and it's successful, the tests are going to instantly improve, and you should see in a matter of seconds a change that's meaningful, and multiple things should change. If you don't get a good change or they get worse, then it's not the right exercise for them based off of the assessment that you took of that person. A couple of things we need to discuss, and this is very, very important. This can get you out of a lot of hot water. If you are a strength coach or a personal trainer, we are not physical therapists. I am not a physical therapist. So we cannot diagnose and treat. Please be extremely mindful of the language that you use with your clients. I will never, ever say, hey, you have scoliosis based off of my pattern. Sorry, let me back that up. Based off of my assessment, you have scoliosis, therefore here are exercises for your scoliosis. But what I might say is that based off of my assessments, you seem to be in a pattern which limits your movement options and quality. This is what I'm seeing based off of that. And here are some exercises to restore movement capabilities to you. You see the difference there? So it is a little bit of a gray area, but we can legally give people exercises, speaking to trainers and coaches, that allow them to feel better if the goal is to help them with their movement. But we never, ever give people exercises where the primary goal is to correct pain in particular. So I'm never going to give someone an exercise for, let's think like a disc herniation. I'm never going to try and say, hey, we're going to fix your disc herniation. But I will say, here are some exercises for your pattern, which may improve your movement. And if that happens to improve your pain along the way, then that's awesome. I usually don't use the word corrective exercise with my clients. I'm going to use it with you guys because you understand we have this sort of general understanding and appreciation for what the word corrective and exercise means together. But I don't like to say that to my clients because that implies that something is inherently broken and it needs to be fixed. Whereas if we call them just fitness exercises, warm up and cool down exercises, positional drills, breathing drills, if you really want to, I like to just call them like positional or reset drills. Now, we have two different types of each of these tests. Some of them have to be passive because it requires two people, but there is an active assessments playlist. We're going to be going over passive assessments because I think that it's way more reliable. I think that there is a lot more opportunity for consistency. And when you have active assessments, usually the issue with that is that there can be a lot of variability. So they could be pulling their leg one way one time, but the next time they pull it differently based off of the experience they had with an exercise, or they just aren't familiar or in tune with their body. So they might just do something that's not what you're looking for there. So I just recommend passive assessments. There is a pretty big correlation between active and passive assessments, but because active assessments would create more active concentric orientation of tissue, some assessments will be a lot more effective than others. And I can help differentiate that for you later, but just take them passively if you can. When you post it in the case studies channel, take them passively. That being said, your clients will want to tense up. They will try to help you. I would say in 80% of cases, if not more than that, that's conservative. People will try to help you in some form with these assessments. When you're doing a straight leg raise, they're going to try and pull their leg up. When they're doing shoulder flexion, they're going to try and assist you and get that arm overhead, which is, it's weird because intuitively you would think like, okay, I want to know where you are because that's going to help me help you best. So why are you trying to show me you have more range of motion than you actually do? It's like, are you trying to impress me? Like, I want to see where you're at and I want to be able to help improve exactly what your limitations are. But if you have, you know, let's say you got someone, you're measuring their shoulder internal rotation, and you're trying to see the side to side differences. If they try to help you out and now it's like, well, you have 80 degrees on your right side and you have 75 degrees on your left side, but in reality, they only had 50 on their right and 60 on their left. That's going to give you a very different idea of what's going on with this person. So if you're ever on the fence, just tell them to relax, shake it out a little bit, get back into it. Yeah, thanks. As soon as you see a deviation, the test is over. Remember, we're measuring relative motion. We're not measuring orientation. If you're doing a straight leg raise and their other leg starts to move noticeably, it's like, well, okay, then that's probably the end of the assessment, because at that point, the only way you would be doing that, the only way you'd be rolling that other leg is if you're moving through both sides of your hips. So that's an orientation. It's very important we have a keen eye to know exactly when someone is done. Okay. First one is a squat. And the squat's a very helpful dynamic assessment, but the problem with the squat is that there's a lot of things that can limit the squat. That being said, it can help you gain an appreciation for how everything together is influencing this overall squat pattern. So first and foremost, to assess this right, our stance needs to be right. We're going to go hip width, toes straight ahead, because that's the assessment for relative motion. That doesn't mean we need to squat people hip width apart with their feet and toes straight ahead. I just want to gain an understanding of what their relative motion is. So we're going to test them in a position that requires a lot of that. Trevor's got a pretty good squat here. It's nice and smooth. Let's look at from the back view what you're going to see here, or a side view. Unlocking at the knees, and a nice, smooth, controlled transition all the way down through those ER, IR, ER zones. Now, you may see a little bit of rounding of the low back in the bottom position, and that's fine. Trevor right here, you can see that there is a little bit of the hips go under him at the very bottom there, but that's okay. If you see a massive or very significant noticeable change in his lumbar spine position, then that's a butt wink, and we would not want that. I think we demo all of the example things that could go wrong here. First, we talk about like, hey, this is what it should look like. This is what is a good example of the execution of this. What is going on out there? Okay. Can you guys hear that in the background? Okay, that's good. Just making sure. So let's take a look really quick at some things we don't want. A hip shift would indicate that the test is over. So if you see the hips start to significantly move to one side, that's the end of the test. And you would stop it as soon as you see that. So they might get down to like 60 degrees, but if you really start to see that happen, then that's the end. If they push their knees out a lot outside of their toes and their toes turn out, that's also the end of the test. If they lose their balance or they lose their heels, that's the end of the test. So we have a couple of key bullet points right here. Butt wink, heels come off the floor, balance is lost, hip shift. Those are the big things to look out for. I think we demoed the butt wink somewhere in here. Yeah, here it is. This is a more exaggerated version of that butt wink. Something like that. Results would be in degrees of hip flexion Okay, we'll get to questions at the end there. So we have less than 60 degrees, can't access nutation or IR because you would be stuck. If you can't get to 60 degrees, you'd be stuck in a lot of anterior to posterior compression. You would probably be in a pretty big anterior orientation, or you could be sway back, but you're probably going to be just so restricted everywhere. If you get to about 110 degrees, then you have the ability to nutate and internally rotate to a certain extent, but you can't re-counter nutate. If you get to 110 degrees or beyond, I generally consider that a full squat, depending on that person's body structure, right? There are other variables that go into that, but beyond 110 or to 110, you're like, okay, that's pretty good. You're really accessing that ER and that re-counter nutation. That's solid. The Ober's test is a really, really essential test, I believe. I think it's very indicative of how neutral someone's pelvis is. So this is probably the hardest test to execute, but it's also, like I said, very, very helpful. Now, what we're looking for is the ability to bring the leg into a hip extended position first, and then drop it easily to the table. I don't want to push more than about a 2 or 3 out of 10 to get that leg down to the table. It should be relatively easy. There are, however, several things that can go wrong here. The first thing is that they're not going to be able to even get to full hip extension. So I think we show from a back view right here. Watch what happens to his low back. Oh, I think that was an example of a good one. Hang on. That, if you see that low back movement right there, that would be the end of the test. That would be him substituting low back extension for hip extension. So let me show you on the pelvis model what's going on here. And while I do that, would you guys mind getting Phil on his side there? Yeah. Where's the other pelvis model?
You have the other. Oh,
I think there's one.
Oh,
yeah,
brother.
that's good. Thanks. So if I'm laying on my side and I'm in 90 degrees of hip flexion, as I bring that leg up and around, I'm bringing it into it. It's a little bit abducted at the top there. But what's necessary is that we're moving towards a hip extended position, and that end hip extension position is internal rotation. If you can't get there, let's say you bring them up around and they get stuck maybe, I don't know, let's say this much shy degree of full hip extension. What they're going to do to get that leg further back is extend like that. And you can see how that's going to bring the leg back in space, but that's just them extending their low back. Once they get to, let's say they can get to full hip extension, from there, they need to internally rotate and adduct that femur. That necessitates nutation, internal rotation on that side. So that's what this test is assessing for. Can you move into nutation, internal rotation to create space for you to adduct that femur? And if you can, then that's an awesome sign. Most of your clients will not pass this on day one on either side because they're going to be stuck in an anterior orientation. They're not going to be able to fully internally rotate and adduct, or they're going to be stuck in a sway back presentation and they're going to be so externally rotated. There's no way they're going to be able to fully bring that thing back and adduct and extend. Let me show you on the big pelvis model what we got. All right. You guys can see this, I think. What's that? I think I am pinned. Yeah. Okay, so first what I'm gonna do is make sure he's got a straight line from his head to his shoulder to his hip. I don't want him rolled forward or rolled back. It should be pretty stacked. I'm gonna stabilize just the side of his hip, usually around that trochanter-ish area, maybe a little bit higher than that. And I'm just gonna pick up the leg. I'm gonna shake it out a little bit, make sure he's nice and relaxed. And then I'm gonna bring the leg up and back, and I'm moving towards that internally rotated position. Do you see what happened right there? Moving towards IR, keeping the knee in line with the foot. I'm not doing this, I'm not doing that, just right in line there. Pick it up, shake it out, bring it back, 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 back. Now, I'm going to just lower him to the table as he goes into internal rotation, adduction, and extension of that innominate bone. And you can see that the femur is going to internally rotate more and more as you move into IR on that side. It should drop and hit the table. Unless they have very, very short femurs, they should be able to get to the table. Things that may happen, number one, other than the low back extending, as you pick up this leg, if they are out of hip extension space, as they dump more and more forward here, you're gonna see this other leg come with them, because that's orientation of the whole pelvis forward, and that's gonna bring that leg with it. Does that make sense? You may also have them come back, 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 but then they roll that shoulder forward because that's them extending their low back to get further back. All right, Trevor, you want to pop up here? You know what might be easiest?
You want to go through all them first?
I think if we just move this skeleton model to, like, if we pull the other table in and just pull this one out. Can you guys hear me okay? Decently? Okay. All right. So Trevor's going to be 90-90 laying on his side. I like around 90 degrees. It doesn't need to be exactly that, but if he's too far down here, then what I run the risk of is missing if that leg is going to travel back with me. So I want him around that range. Probably I'd say right about there. Okay. So he's got his head in line with his shoulder, in line with his hip. I'm going to stabilize just very lightly right here. I'm going to pick up the leg and I'm going to shake it out a little bit. My little test to see if he's staying relaxed, because this is the test that people cannot show on the most. I'll just drop the leg. And if it drops, then that means that he is relaxed. But if it stays up, that means there's tension in his body. So I'll make sure that he's nice and chill. He's got a heavier leg. I'm going to pick it up and pin it in here and go here. But he doesn't have an extremely heavy leg, so I'm not too worried about it. I'm going to pick it up, pull it back, 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 back until he's in line. Looks good. I'm going to drop him down to the table. That's a pass test. But if I got stuck right here, that would be a pass test. What you're usually going to see.
That'd be a failed.
Oh, that'd be a failed test. Sorry. Yeah. So we went right here and he started to come with me here. That's no good. That'd be an orientation. You might see a tiny, tiny bit of movement right here, but that might be representative of him just not having that much hip flexion that he was starting in. Just keep that in mind. But usually if you're starting him around 90 degrees or maybe slightly less, things are going to be okay. So the other thing is that shoulder rolling forward. Let me show you that. That is going to make it really easy for me to drop him. The other thing is if you come back and you get to that straight line, but you can't drop him without that femur coming forward, that is not a pass test. It's got to be pretty easy. So I could just drop his leg, no problem. But if I look, let's look at his other side just for comparison. So that was his right leg. Now let's look at his left leg. Pick it up, back. There's a little bit more tension in this leg, I would say. Almost, but not quite. It's not quite all the way there. Now, let's see, am I missing it? There's one more thing I wanted to hit on this.
You want to do the rib flare?
The rib flare, yeah, that's the extension. I think that was it on it.
What was the foot?
Oh, the foot, right. So make sure that the knee stays in line with the foot. If you see this, it's not good. You gotta keep it relatively in line. Cool. So that's the IR test. One of them, at least. If your back arches before you get the hip extension, you don't have hip extension, you're substituting low back extension for it. If you're halfway to the table or less, you're missing some degree of internal rotation. If you're all the way to the table, that's awesome. You probably have access to at least some IR. Hip flexion is an ER test. And I like passive hip flexion much more than active hip flexion. I find that active hip flexion is actually a lot less than passive because there's so much concentric orientation of tissue that you recruit. But when you're in a passive version of this, you can really get a feel for how much ER space that an individual has. So I'm going to pick up the leg and just make sure I'm perfectly in line. I'm going in a perfectly straight back line. I'm going to stabilize the top of the knee. And the biggest thing I'm looking for is once I see significant movement of that downside leg, if you look very carefully, right here, you're seeing a little bit at this point, but it's not meaningful. The leg hasn't lifted up all that much yet, so I'm not too worried about it. But once I get to maybe right about there, that would be the end. So do you see how you start to see that downside hamstring lifting off of the table? That is the end of the test because that indicates that he is moving into a posterior orientation of his pelvis to find ER space. Similarly to how the Ober's test, you will extend and anteriorly orient to find IR space. You will posteriorly orient to find ER space here. So let me see if I can show you a nice straight line. There should be you should not really be able to see the heel. If you can, then they're probably abducting their femur. Now, once you get to the end range, what you're going to see is that's going to happen. They're going to want to abduct their leg because that would be them trying to roll towards that side to find external rotation. We turn towards ER to find it. We turn away from IR. So this would be him rolling towards that side to find ER space. What you're testing for is femoral external rotation, pelvic counternutation, and ER, abduction, flexion. As you externally rotate that leg in that 0 to 60 range, shouldn't be that hard for most people. And then you will, yes, relatively move into some IR in that 60 to 100 range. And then beyond that, you externally rotate more and more. And you should eventually, an ideal range of motion be knee to chest, but at least past 110, 120 degrees would be good. You have much more passive hip flexion than you do active. Active hip flexion usually tops out around 120, but here you can go all the way knee to chest because it's totally passive. What that's testing for beyond about 100 degrees, remember the hip flexion arc, is that you're going to have the sacrum turn towards that side, and you're going to have max ER. So this is a representation of how well can you turn your sacrum towards that side. If someone really sucked at heel strike mechanics, which is where the sacrum turns towards that side, the stance leg side, I would expect them to be limited in hip flexion. If you feel any pinching of the hip, that's the end of the test. So those are the big things. Leg coming off of the table, the femur abducting of the active leg, active meaning the side you're testing, and that pinch, any restriction. But what's cool about these passive tests is that if you have some pinch or some restriction, they feel it at pretty much the exact same point that you're going to feel it. So I always like to check in and say like, hey, are you feeling this right now? And they'll be like, yeah. And that's a good, if they're getting a pinch in their hip flexor, then maybe you do an exercise and you give them the right thing. And now they have way more range of motion and that hip flexor pinch is gone. That's one of those tests that really helps for people to feel that it's better. Hip flexion is easy to feel when you make a good change. So what I'll do is I'll just pick up the leg, I'll bend it, and then I'll guide it back. So in the 0 to 60 range, I'm in more ER, counter nutation. 60 to 100 is relatively more IR, but still you're in an overall ER bias. You're just less in this range. And then at that very end, you're going to have external rotation of the femur. You're going to have the sacrum turn towards that side, and you should be able to get them all the way to the chest eventually. No one's really going to get there immediately without seeing this. If you see this, that would be this extended leg coming off of the ground. You see how that would create a bigger gap between the hamstring and the table? If I did that right there, that would be them rolling towards that side to find external rotation space. The other thing you are very commonly going to see is if I'm in an extended position to start with and I lay on the table, that's going to put me already in a passively hip flexed position. So what you're going to see is a big gap between the hamstring and the floor on both sides or one side. So if I'm just laying on the ground in a supine position with my legs extended and you see a gap between the hamstring and the floor, that person's starting extended. So you may have less hip flexion in those circumstances because they're already starting in a position that's going to block their ability to access ER. Or what you may see is them just orient harder because they need more space. So those are the big tells. If you see the other leg move, if you see the pelvis dump under, or you feel a pinch somewhere in there. And the pinch is so common because remember, so many people are starting extended that they're going to run into a point where they're going to impinge somewhere in here because they can't get that ER space because they're stuck forward. All right, Trevor, let's see what you got. Okay, so I'll just make sure he's straight. I don't want him to the point where if you scoot off the table a little bit for me, this is not what you want because this is going to passively extend him. So we're going to get you flat there. I'm going to pick up one leg, bend it, and then guide it back. My eyes are looking at that downside leg and also the pelvis, trying to determine the point at which you really start to see movement. You see how his foot moved a little bit? It just went back in place, whatever, not too worried. But right about here is where I feel that he's done. And you can see that downside leg start to come off of the table as well. So I would call this maybe about 120-ish degrees. Now we'll compare the other side. Right there. And this side is a little bit easier. I'd say this is more like 130. You see, again, a little bit of movement here, but it's not so much to where it's significant. He's moving like a couple of millimeters. It's not the end of the world. That could be me pushing on him, which is creating that turn. Something that would be significant would be like that, or here, just totally relax. Something like that. That foot movement would be a lot.
Very comment on this.
Yeah, go ahead.
Something that helps is to go really slow, and if you're not sure, like Connor was saying, with the heel going out or in, is just if you just use the least amount of tension possible and guide the leg forward, you'll feel when it wants to track out, which is where it's generally going to go.
Can we turn you so that way we can see from downstream?
Yeah, sure.
Yeah, that should work. All right, so if I guide him straight back, his left side was better than his right. Notice how that's a nice straight line. Right about there. You can see how if I went further back, that leg would move. However, I can get him further back if I abduct his leg and push him back further. I just got an extra 25 degrees by doing that, but that's not genuine relative motion. That's me rolling him towards that side so he can find ER space. So currently, Trevor has better external rotation on his left side and better internal rotation on his right side in terms of those measurements because his Ober's test was better on the right and his hip flexion was better on the left. That checks out. straight leg raise. Now, this is also technically hip flexion, but it's not an ER test, it's an IR test. And the reason for that is because we have something called the screw home mechanism. Hang on one sec, guys. I feel like my computer's being a little laggy right now. My video looks pretty good. I'm just going to close something really quick. There we go. Okay, that should help. All right, so when we have a straight leg, we lock out the knee. This creates relative femoral internal rotation with tibial external rotation. Now, when we think about the hip flexion arc, think about the squat. What is the knee doing? It's moving into flexion. Knee flexion is the opposite of knee extension. Knee flexion would be relative femoral external rotation with tibial internal rotation. So knee flexion allows us to access ER. Knee extension creates and necessitates internal rotation earlier. Therefore, we are going to need to get into IR sooner in this hip flexion arc than we would otherwise. So you're just going to make sure the knee stays relatively straight, and you're going to be watching for more or less the same things as the hip flexion test, honestly. Once you see about that, you see them start to lift off of the ground there, that would be the end of the test. You don't want to actively dorsiflex or plantar flex too much. You just want to make sure that it's relatively chill. It's a pretty chill movement, staying in line for the most part. From 0 to 45 degrees, this is where you have that ER. But remember, you need IR earlier. So 45 to 90 degrees would be that IR range now. You need to be able to open up the back side of the pelvis and move into, remember, this would be posterior expansion of the pelvis at 45 degrees. If you can't do that, if you can't get to 45 degrees, then you have all this tightness of the deep hip external rotators, like the obturator, gemelli, piriformis to a certain extent, would all be jamming this space shut, keeping your femur ER'd, and you would not be able to open up that space and get to 45 degrees or more. You progressively need more IR the more you get beyond that. You don't want to go beyond 90 degrees, because if you do, then that would be representative of an individual who has a very either eccentric strategy on the back side of their pelvis and or large orientation driven strategy. So if someone is very, very extended, think about like your yogis who have, you lay them on the ground, they're already starting in a hip flex position. You lay them on the ground and all of a sudden now they're getting to 120 degrees of a straight leg raise. That's not good. I don't want that, because that tells me their strategy for IR is straight up orientation. So I want those people to actually get a worse straight leg raise. I don't want them to have more than 90 degrees, because that's just so much more than you need. And that person probably doesn't have a lot of stability either. They don't have an end range feel. Let me see if there's a couple of things that we can demo here. Oh, if the knee can't stay straight, that's a problem. So if you see the knee unlock, that would be indicative of the end of the test. If you see them do that, if they roll out like that, and that femur abducts, what you're going to see paired with that is that downside leg is going to turn away from that side. Whereas in hip flexion, you're going to see it roll towards that side. What you're going to see here is as you get beyond 45 degrees, that downside foot is going to turn out. And what that's representing is them turning away from that side to find IR. Hip flexion, we turn towards to find ER. Straight leg raise, we're going to get to 45 degrees. We're going to turn away from that side. You see that? We're going to turn away from that side to get IR. All right, let's go over here. Yeah. 0 to 45 degrees. Well, first of all, if I just straighten out my knee, that's going to create internal rotation, external rotation, IR of the femur, ER of the tip. As I go up, I am, yes, more externally rotated, but once I get to about 45 degrees, I'm going to start to internally rotate more and more and more. You see that? It's kind of, look at the head of the femur right there. ER, IR, turning in up to about 90 degrees. We don't want to go beyond that because that would be indicative of that person just orienting their pelvis back further. If I didn't have that space, I would turn away from that side and this leg would fall to the outside. You would see the toes do that. You would see the toes turn towards that direction. In order to get to 45 degrees and more, remember the backside of the pelvis has to open up. You have to access that nutation to a certain extent. All right. So let's think about what we have with Trevor so far. His Ober's test was better on the right. Hip flexion was better on the left. So straight leg raise is more of an IR test. So I would hope that his straight leg raise is better on the right than it is the left, because that would make sense. Here is his right. Again, I'm going to just keep a very slight pressure on the top of his knee. I'm not going to hyperextend his knee. I'm not going to actively pull his toes back really hard. I'm just going to make sure he's nice and relaxed. And we're going to go up to the point where he feels a restriction. Well, you're tight today. Probably. Right here. So he's at about 55 degrees, maybe 50 on that right side. His left. Right about there, that's about 45 degrees. Usually Trevor's straight leg raise is better than this, but this is, did you do legs yesterday or something?
Earlier this week.
Okay. So his left is worse than his right, but that checks out with what we know. So if I were to push him further than what he's capable of, that would just happen. And also, I could roll him away from that side beyond 45 degrees and get him way higher. That's just him turning away to find IR. Does that make sense? All right. With these tests, as I'm going to touch on more and more, things should make sense. Next week, you're going to see compensatory patterns and how we measure them, how we understand where someone is lateralized to the left, right, or some combination of. If I have good IR, other IR tests should be better. If I have good ER or ER to a certain extent on the other side, other ER tests should be good on that side as well. You see where I'm getting at with that? Things get harder when things make less sense because you have some tests telling you one thing, some tests telling you another thing. You're going to see that, but I'm going to show you next week how you can differentiate where someone will be and what you can do. Passive abduction. This has become more and more of an essential test. What you need to do here is get them in a position where they're not going to cheat by crunching their top side ab wall. So Trevor's got limited abduction for sure on this side. He's getting to about maybe 15, 20 degrees. And the reason for that is because this is testing his right abduction, and that's going to be limited because it's an ER measurement. His IR is better on the right, more limited on the left, and vice versa for his ER. So when you do this, it's important that you have a straight line from his head to his shoulder to his hip to his foot. That towel underneath that side right there is allowing him to move genuinely through his hip, because what the biggest compensation you're going to see here is, you're going to see that. And that is all just crunching with the abs rather than staying here and getting that genuine abduction. So I encourage you, to place that towel roll there when you can. Sometimes you're busy, you got a lot going on in the gym, so maybe you just don't do it. But it's ideal to start to know what it feels like to see those abs crunch on the top side. The downside leg is around 90 degrees, maybe 80, whatever. It doesn't matter all that much, as long as it's beyond about 60, 70 degrees. And then we're just going to make sure he's relaxed, making sure that you have a straight line here. I like to stabilize the top of the hip, keeping that leg pretty straight. And we're just going to go up until we feel that side bending or some impingement sensation or some sort of leg or hip flexion, meaning that the knee bends or the hip bends. That would be the end of the test. So what you need here is counter nutation and external rotation. So we need ER more and more here, but you also need that counter nutation like that. Hip abduction, I like to think of it as a representation of how well you can get out of one side. If I'm buried in my right side, how well am I going to be able to abduct my hip? I'm not. But if I'm shifted to the right, can you see how my adduction, my obers will be better on this side and my abduction will be better on that side? Vice versa for the other. It's pretty obvious how that would work, right? This is going to have better IR. This is going to have better abduction ER. So I'll have. Yeah, let's use. Oh, I'm about to write it. Thank you. This is going to go underneath the low ribs. It's not going to go underneath the hip. I want the hip flat on the ground or the table. Stacked position right here. Okay. I'm going to make sure everything is in line. And I'm going to stabilize the top of the hip. And I'm going to go up. And this is more and more ER of the hip and the pelvis, stopping at about 45 degrees. You can go higher than that, but 45 degrees is at least what you want. So you're going to see starting in more IR because that's hip extension, but as you go up more and more, it's going to be ER. ER. All right, Trevor, let's get you up. Biggest compensations you're going to see on this have to do with how we find ER. So you might see them roll towards that side or move into hip flexion because that would be them looking for ER. So Trevor, let's get that top. Let's throw that underneath your side. All right. There. There. Okay. Roll the, make sure you get a slight roll forward of the hip and make sure that the shoulder's not rolled excessively forward. We want it back right here. Head's in line, looks good. I've started to grab around the knee area more lately. I think it just helps more, shortens the lever a bit. We're gonna go up to the point where he feels a restriction. I feel a restriction too. And if I went up any higher than this, if you can bring this up, if I went higher than this, it's all just side bending and hip hiking. See that? So I want to make sure that he's moving genuinely to the point where I feel that, which is right about there. I would call this about maybe 20, 15 degrees. I'd say probably more on the 15 side. I could get more if I rolled his hip back. Now it's way easier, but this would be him rolling to that to find ER. Or if I brought him in hip flexion, that can also make it easier. So it's got to be that straight line. Most people will screw this up by not keeping the hip rolled over and parallel to the wall ahead. You don't want to go too far, but just enough.
The other side.
Oh yeah, let's compare the other side. So that was his right abduction. Let's look at his left. We know that his left hip flexion is better. Rolling the hip forward, right here. Any more than that, it's all abs. So I'd call this about 35, 40 degrees, probably more like 40. And this is way better than the other side. It also feels way better too. So he's got better abduction ER on his left, which makes sense. Better adduction and IR on his right, which makes sense. Therefore, when we were to intervene with Trevor, give him a drill, you should see improvements. Let's say like we're going after ER on the right side, because that's clearly what he's limited in. Both abduction and hip flexion should feel better. Yeah, again, like how well can you get out of one side? How well are you going to be able to shift into your right and push out into your left and accept that? Femoral rotation. Okay, so we like to do this in a seated position. You don't have to do it in a seated position. There is a supine variation, as you guys will see on the playlist. But how you measure this will alter what you are capable of expressing. So in a seated position, you're obviously in 90 degrees of hip flexion, or I hope you would be around there. Because of that, you're biased towards an internally rotated position because of that hip flexion arc. So you'll be able to express more internal rotation in this position than you would if you were supine and you had your leg flexed. I'll show you both to kind of illustrate what I mean here. But generally, you want to make sure that the knee is in line with the hip and also the foot to start. This is 0 degrees. Beyond that, right here, Trevor is getting to 30 degrees on that side. And as he goes into ER, you're looking for the hips, again, not moving much. And he's getting to about 25 degrees there on his left side. What you don't want to do there it is. What am I talking about? You don't want to extend on the table. You don't want to flex on the table. You want to just have your sit bones in contact with the table, and you should feel like you are relatively upright like that. I think I demonstrate the hip hike situation. Let me see if this is it. We'll show you live. Okay, let's have you pop up. There you go. Push just that way. Yeah, that should be fine. So what I'll do is I'll have him feel his sit bone, sit tall, even sit bone contact on both sides, making sure he's not out right here, he's in right here. So that looks pretty good. Let's go this side first. I'm going to stabilize the top of the knee, and I'm going to bring him out. Right about here is where I feel like he's done. I would say that's around 25-ish degrees, maybe 30. If I went any more than that, he would hike up and roll away from that side. Do you see that? That's him rolling away to find IR. That's not where he's done. He's done really right about here. Now for ER, it's a little trickier because you have this leg in the way. So you got to make sure that you're just pulling it back a little bit, but still keeping the knee in line with the other knee. So just right about there is good. Now, as we go into ER, he's got about that much. I would say this is about 30-ish degrees, maybe 25. If he went up any more than that, he would roll towards that side, and that femur would go up into flexion. Now let's compare that to the other side. So his IR on the right side, relax for me. I'd say right about there. Any more than that, he would hike up. This is about 35 degrees, I would say. So that's a little bit better than his left side. His right ER, I would say, is about 15 degrees. So his IR on the right is better than the left. His ER on the left is better than the right. This allows him to express more IR. Remember that. If I laid him on his back, put him in a supine position, you can measure it like this too. Honestly, guys, I don't care all that much. Just keep it consistent. Remember, when we're laying on our back and we bring one leg into hip flexion, the pelvis is relatively more turned towards that side. So he'll be more easily able to express external rotation than internal rotation in this position. Sometimes it's a lot different, depending on some individual factors. Other times it's relatively the same, but there is still a slight difference. So what I'll do is I'll pick him up and bring him to 90 degrees of hip flexion. His external rotation on the left now presents, he's done right about there. This now looks like it's about 30, 35 degrees. And his IR looks like it's now only about 20 degrees. If I go to this side, his IR, I'd say now is only about 20 degrees, 25. On this, ER is now upwards of 25 degrees. So you see there's about a 10-degree-ish difference. The problem with a supine measurement is that it's much easier for this person to roll without you seeing it. The reason we like seated is because it's very easy to see when that hip hikes up. It's also easy to adjust. So if someone doesn't have 90 degrees of genuine hip flexion, all you would have to do is prop Trevor up and have him sit a little taller, sit a little higher. So you put some books underneath his hips, you can put him on a seat, whatever. You can just take him out of the hip flexion he doesn't have. So that's the lower body. Let's do the upper body now. Shoulder internal rotation. This is a representation of anterior expansion. You should be able to get relatively easily to the table without that shoulder popping forward. External rotation, we'll talk about in a second, but this is anterior expansion or pump handle. Internal rotation space is taken up more and more as we go into IR. However, if you are already starting in a down pump handle position and your shoulder is, let's say it's rolled forward, then what you're going to see is you're already taking up a lot of that IR space. So you're going to be limited in your ability to express it. But you may present with ER still. It just depends on what you look like, honestly. We really want to make sure that the shoulder stays down here because we're going to make it real easy for you. Shoulder IR gets taken up more and more. However, if I don't have that IR space, look at what happens here. The shoulder's going to pop forward, but that's me turning away from that side. That's me turning away to find IR. That'd be represented by this. Try this. Get your elbow right out from your shoulder. Make sure it's in line. Drop it to where you feel a restriction, and then just turn away from that side. It's easier, right? That's what would be happening. So the more pump handle down, the more anterior compression you have, the harder this is going to be. $70 degrees is generally okay. I would say that checks out. You probably have some anterior expansion available to you, but 90 degrees is best. Shoulder ER, 90 degrees. You can have more than 90 degrees of shoulder ER for sure. But shoulder ER, to be honest with you, is probably the most easily cheated test because the way that you're oriented on the table can matter so much. So that was IR. ER is the same thing. Just go back. It should fall relatively easily. So Trevor gets to about 95 degrees there, which is fine. And this is testing for posterior upper expansion. This is testing for the ability for you to get the scapula to just glide and access the relative motions with the humerus. And I'll show you what that looks like in just a second. The thing about external rotation of the shoulder, though, is that depending how you're laying on the table and your starting orientation, it can be really easy to, well, we have different tests that will check posterior expansion, but it's very easy. If you're already starting extended, that's really just a joke. Now, ideally, you'd be testing for those relative motions. And if you ran out of space and you got to here, you just turn towards that side. And that would be you finding ER. So let me show you something. When I move into external rotation of my shoulder, sometimes this thing behaves, other times it doesn't. This is you moving into more upward rotation. Okay, so if I had posterior compression, I couldn't get that from T2 to T8. I wouldn't be able to get my scapula to move away from my spine. The inverse would be true for internal rotation. It's just doing it on its own. Good. That'd be more down. It's hard. You need more downward rotation with IR. So if you had a lot of anterior compression pulling your scapula forward, you would not be able to access that IR. That's the relative movement between the scapula and the spine there. The scapula and the humerus and the spine. So hopefully that helps you illustrate how there is that rib cage component and that spinal component that has to do with the rib cage, but you also have the humerus and the scap acting in that manner as well. Trevor, let's have you pop up. Okay, so this is his left side. I'm going to make sure, again, he's straight. Everything is in line. I don't want to start too down low. If you start him down here, everyone will pass this test. You want him to be able to start at about 90 degrees, and then the elbow and the wrist is nice and relaxed. You're just going to drop him down. That's easy. This is full. Going back into ER, I would say he's 75-ish degrees on this side. So maybe 15 shot. However, if Trevor were to extend his back, super easy. So when people have full shoulder ER, but their other shoulder measurements are limited, you can be a little skeptical because they're usually starting just extended. We'll just, yeah, if you spend that'd be great. Shoulder IR. This is a little worse. I would say this is about 60 degrees. The shoulder ER is full, and I'd say it's more than full. It's about 100 degrees. So he has, based off of this test, more limited shoulder IR, that's more anterior compression on the right, more limited shoulder ER, that's posterior compression on the left. So he has more left anterior expansion, more right posterior expansion. That's a right turn. Does that make sense? So this is what you would expect to see if you think about last week's content. So what I would expect to see now is when Trevor, when we go ahead and assess other things of his shoulder and rib cage, he should present with more limited right anterior, left posterior measurements. Things should make sense. They won't always, but ideally they will. Shoulder abduction, I think it is an essential measurement because it's representing how well you can essentially turn towards one side without orienting. You're just dropping, and once you see significant movement like that, you see at that end range, Trevor really started to turn his rib cage towards that side. That would be the end right there. So he would be done just a hair shy of that, probably right about here, because at that point, he just orients and turns his entire rib cage towards that side. So the question is with this abduction, how well are you able to get your scapula to move back on the rib cage on that side? Because if you already have a lot of posterior compression, that scap's not moving. It's not going to be able to migrate back. There's no space for it to migrate to. It's not going to be able to access that downward rotation. No chance. But also, if you're turned towards one side, this is now way easier. This is way harder. Do you see how that works? If I turn left, this is going to be easier. This is going to be harder. That's how I explain it to my clients, and it makes a lot of sense. Everyone tends to get it when you put it in terms like that. So you need posterior expansion here for you to migrate your scat back on that side. There is an anterior expansion component too, but I want you to think about it mostly as if it's a posterior expansion test. All right, Trevor, let's have you pop up. So he had better right shoulder ER by a noticeable bit. So he should have better right abduction. That's what we would expect to see. Top down would be good. So you want to make sure he's off the table enough to allow for that scap to go back, but he shouldn't be so far off of the table that he's starting like that. So you want him to be neutral, which appears to be right about there. I'm going to make sure his palm is facing the wall over there, and I'm just going to drop him. If I keep going, you guys can see right about there. If I went any further than that, he would come with me. So he's about 30 degrees. Let's go to this other side. Maybe just do a tiny bit that way. Yeah. And this is maybe 10. If this is 0, he's right here. It's about 10 degrees. If I went any further than that, he'd come with me. You see that? Thank you, Chair. You want to make sure that you're staying nice. And if this is 0 degrees, this is perpendicular to your body. You want to keep that palm in that same plane as you go back. If you drop it, it's way easier. If you do that, it's way easier. So he has 20 degrees better abduction on his right side relative to his left. That checks out with exactly what we would expect. Shoulder flexion is probably the hardest upper body test to take, but it's very helpful to understand full scapulohumeral rhythm mechanics. I promise you, 99% of trainers and therapists think that their clients have more shoulder flexion than they actually have. So I'm going to play this video for you because it's a nice sort of zoomed in look. Let me make sure something really quick. Speakers. Settings. Huh. I'm not sure if this is going to play. What's that? You had a problem with him too? Okay, that's all right. We don't need to show you the audio. We can just show you. The idea is that you always want to start down by the side. You don't want to start testing shoulder flexion at 90 degrees of shoulder flexion. You want to go down below. You want to grab the arm, make sure it's nice and relaxed. And you're just going to grab around the epicondyles and just guide it back very, very slowly and relaxed. The second you feel, literally the second you feel the elbow start to migrate outwards, laterally, away from the body, that would be the end of the test. Because that would be him orienting, and that would be him turning to find ER. You really want to make sure that you're going relaxed here. Most people just shove the elbow overhead. They don't think too much about it, and they can cheat it really easily. So once I feel that start to turn out, that would be the end. If you want a more effective way to do it for some people, I believe I discuss it in the video. I discussed something called the skin lock technique. Yeah. You see, I'm grabbing that medial epicondyle and twisting out. That's going to essentially just create some friction between my hand and his elbow, and I'll feel the skin start to twist in the opposite direction, and then I'll know he's done. That's another easy way to do it. So from 0 to 90 degrees, that would be an indication of posterior lower compression of the thorax. That's below that T8 region. because we haven't gotten, it's not 0 to 60, because remember, from 0 to 60, we have a lot of kind of passive scap movement, a lot of active humeral movement. So we haven't really gotten the scap to do much yet. But at 90 degrees, you really start to see that upward rotation of the scapula. So at that point, if you can't get beyond 90 degrees, that's a representation of you having very limited compression below the level, or very, very significant compression below the level of the scap. So let me show you what we got here. So bending the elbow, 0 to 60 degrees, not a lot of movement yet. You start to get a little bit, but then once you get to 90 degrees here, you start to see that scapula. Start to see that scapula start to upwardly rotate more and more. You start to see this happen. And if you can't get this upward rotation to happen, then you know that that scap is being compressed against the rib cage, probably from stuff like tight lats, which is driving this down and preventing it from upwardly rotating. But from 90 to 120, you're getting more expansion. Well, you need expansion and space for the rib cage to actually, allow the scap to move away from the spine. So you need this posterior expansion to a certain extent from 90 to 120. Beyond 120, you need more upper expansion. You need more of that T2 through T4 area. And you need to get that last little bit. Most people don't really need more than, like, when people have 120 degrees of shoulder flexion, it's genuine the way we measure it, they usually feel pretty good. 140 degrees would be better. I don't know if you really need to get more than 140. I think you're going to spend a lot of resources and time on something that most people don't need. I have found a pretty consistent theme. Like if you have 120, 130 degrees, you're probably feeling pretty good. But this is how you would identify exactly what you're seeing there. So let's have Trevor pop up. Remember, he's got, if we're thinking about shoulder flexion, there is an anterior expansion component for sure, especially in that 90 to 120 range. But this is mostly a posterior expansion measurement, mostly. So Trevor has better abduction and ER on his right, so he should have better shoulder flexion on his right as well. That's what we would expect. All right, let's see. I'm going to go this side first. I'm going to make sure that you're nice and neutral right here. I'm going to grab epicondyle right here. I'm just going to make sure that he is chill. And I'm just going to very gently guide this arm overhead. And once he feels that first little bit of him wanting to turn out, which I'd say is right about here for you, that would be the end of the test. He feels it in his lap. So we're going to go nice and easy, up, 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 up. I'm almost barely holding him at all because his shoulder will tell me what's going on. Right about there. Yeah. So this is 105-ish degrees. That's his right side. Let's check out his left side. Could you flip around actually? Start down. Don't start up here because some people might not even have this. Start down here. Guide it. I'd say right there. Right about here is where he starts to turn out. So this would be about 90, 92, 93 degrees, 92.4.
Radio station.
Right there. Yeah. So that's where I really feel him wanting to turn out. Let's show a top down because I think that'll be really helpful for you guys to see. Taking this test actively sucks. It's really, no one can do it. Down by the side here. Nice straight line, as you guys can see. What you're gonna see when they're done, you're gonna see that. This. Any bit, even that, they'd be done. It's really, really subtle, but if you're staying relaxed, I mean, I could. Oh, your shoulder flexion looks great, dude. But this is me shoving him into this position. Thanks, Trent. Yeah. So his right shoulder flexion was better than his left. Every test he has checks out exactly as we would expect, which is very helpful for us to understand what's going on with his body. Oh yeah, that is a common question that we see. Why don't you test it with a straight arm? Well, a straight arm, if you have that, it's much harder to sense when that elbow's turning out, but also this is going to allow you to, in my experience, it's more representation of relative motion, whereas this creates, I mean, both create relative eccentric and concentric orientation, but with this, I find there's just more tone within the body when I measure people, and this just allows them to relax everything. So I like to do the bent or just like around 90-degree variation of that. I don't go all the way flexed. I don't go all the way extended, just somewhere where they can stay really chill. And trunk rotation. This is an upper body and lower body test. Honestly, we've been looking at this as more of a lower body test recently, because the way that, despite it being called trunk rotation, the way that this is working is it's basically just holding the thorax steady and stable, and the pelvis is turning towards one side. So think about this almost as if, how easy can the pelvis turn towards one side? They're going to stay in abduction because you'll know they'll be done. The tell for this is when you see that downside leg start to move, or the downside arm start to move. That would be the end right there, because that is a very easy indication visually to determine when they're moving everything else and not just rotating through their hips. From a downstream perspective, I think what I'm doing here is illustrating how you can measure it and like really get an idea for where someone's done. You can see that he's done right there. Yep. So I can grab a pole or something and just measure where he's done. That's one way you could assess it. The other way you can assess it is just take the line from that crease in between his thighs and use that as an indication for where he's done as well. Because that, if starting is 0, knees directly up at the ceiling is 0 degrees of trunk rotation. Right there, that'd be 0. And then as he goes more and more into that, he would be done. So if I called it done right here, this looks like it's around 45 degrees. Ideal is about 70. All right, let's have Trevor pop up. No, we don't. All right, let's get you. So we know that his knees should rotate more in the direction his pelvis can turn more easily. We know that he's probably turned right based off of all of his assessments. So I'd really expect his right trunk rotation, or his knees right is what I mean by that. Knees going right should be easier. Oh, okay. Yeah. So I'm going to put my palm of my left hand on his right ribs. I'm going to use the other hand to keep them together, and we're going to go off to the side. Right about there is where he would be done. More than this, he'd come with me. So I'd say that this is around 40-ish degrees. It's not a perfect science right now. Let's go to the other side. Right here. So this is definitely more. I'd call this upwards of about 60, 55 degrees. So his knees going right is easier. And that's what you would expect. Actually, let's show him what it looks like when it's not good. Let's have you just, I'm going to push you beyond what you're. Oh, well, why are you arm off against go on? If I were to push him past what he's capable of, then he would just start to do that. So that's really important to know. That's why I'm watching that arm and shoulder, because this will dump forward when he's done. All right. That's a really helpful test. That's one of those tests that I find are kind of like a tiebreaker. If I don't really know where someone's pelvis is turned towards, because other things are telling me like it's all over the place, that test is something I put more weight in. And now we're going to talk about the expected overall testing results of your primary asymmetrical presentation, which is what we would call that right lateralized pattern, that left AIC. Within a squat, you would expect to see a slight right hip shift, if any, because they are loading their right side more. In the Ober's test, you'd expect it to be better on the right. So whenever I say better on the right, I mean like both sides could suck, but the right side's better. Or both sides are great, but the right side just feels a little easier. Hip flexion will be better on the left than the right because this is an external rotation-based measurement. Straight leg raise will be better on the right because it's more of an internal rotation-based measurement. Hip abduction will be better on the left because that's ER. Trunk rotation will be better knees right than left. Hip IR will be better on the right. Hip ER will be better on the left. Does this all make sense based off of what we talked about last week? Shoulder IR will be better on the left. Shoulder ER will be better on the right. Shoulder IR will be better because it's an anterior expansion measurement. In the normal asymmetrical pattern, recall that we have an expanded left chest wall, compressed right anterior chest wall, compressed left posterior mediastinal or rib cage cavity, and expanded right posterior mediastinal cavity. So we have better ER measurements on the right and better ability to turn to the right relative to the left. Now, remember, everything should make sense, but there are some instances in which you're going to see stuff that doesn't make sense and you're going to be a little confused. Here are common ways that people cheat these tests and common ways that you're going to see certain things be way better than they should. If someone is in a significant posterior orientation of their pelvis or thorax, usually it's going to be one or the other. If someone is in a posterior orientation of their pelvis, they're probably not going to be in a posterior orientation of their thorax because they would lean back too far. Usually they'll be in like a sway back presentation. So their rib cage will be dumped more forward. So let's go through these individually. Posterior orientation of the pelvis, you will be able to cheat hip flexion and your squat more easily because you can cheat that hip flexion and those ER measurements, but they will still have limited trunk rotation and Obers. They're not going to be able to cheat those. If you have a posterior orientation of your thorax, it's tipped back, you have a lot of rib flare. This is usually paired with anterior pelvic tilt. They will have better shoulder ER and potentially better shoulder flexion than they should, but their shoulder abduction will suck because shoulder abduction is a representation mostly of posterior expansion. If that's limited, then shoulder ER should also be limited. But if shoulder ER is not limited, then it's like, well, what's going on here? Oh yeah, you have a ton of rib flare on the table. I'm not going to pay attention to that shoulder ER measurement too much. If I have a huge anterior orientation of the thorax, and guys, this will be just visually present and clear. It's not something you really have to guess at. It's like, oh yeah, your shoulders are like dumped forward. You're going to have a lot more shoulder IR, and you may have a huge straight leg raise too, because you have been so far forward that you have really long hamstrings, if you want to think about that, because your pelvis is so far forward that you're going to cheat that. A lot of yogis, a lot of females with sort of more narrow body frames and are very flexible will have a lot of anterior orientation and a huge straight leg raise. And shoulder IR will feel really good, but it's like, well, that's weird because your shoulder ER kind of sucks, but your shoulder IR is really, really good. And your shoulder abduction and flexion are also not that good, but you're just dumped forward. So that makes sense as to why you would express more shoulder IR than you would actually have. What's okay about this, though, is that you still have limited shoulder abduction, trunk rotation, and Obers. Those are the three tests that are going to be really hard to cheat. So let me simplify it for you even more. If you're confused, work off of their worst measurements. Some of the assessment compensations will be hard to visually see depending on the individual. Using their worst test to guide intervention is often the best way to go. So if you're ever like, man, I don't really know what's going on here, and I'm seeing so many conflicting points, so many conflicting data points and assessments that I just don't even know where to start. Well, let's think about it. Straight leg raise is huge, but their Ober's test is really limited and their hip IR is really limited. Well, that straight leg raise test is probably not genuine. The lighter someone's body frame is, the lighter their limbs are, the easier it is for them to very subtly roll during these tests. And you're not going to be able to see it visually unless you have a very keen eye. I don't expect you guys to get that, but the better you get at these assessments, the more you're going to be able to identify visually, like, oh, you weigh 90 pounds, but I see when you start to orient now because I know what to look for. But initially, you guys are going to be thinking about too much. Don't expect that immediately. If their squat is 70 degrees, but their hip ER is 40 degrees and their hip flexion is 70 degrees, what? Oh, just go off their squat. If their shoulder ER and shoulder flexion seem to be pretty good, but their shoulder abduction is 0 degrees, well, then just go off of their shoulder abduction. That's the one to go off of. And I guarantee you in 80, 90% of cases, if you just follow this principle, you're going to be okay. But you still want to know what the shoulder abduction, ER, and flexion are relative to each other so you can identify side-to-side differences. And the lateralization chart is really going to help us appreciate that, because bilaterally stuff matters and it's important. But what I really care about, what I hope you learn to really care about, is the differences from side to side. Like I mentioned, the beautiful thing about this whole process is that there is instant feedback of how effective our interventions are. So we can assess someone and give them a 90-90, give them a bent over posterior expansion, give them a little rolling drill, give them a right glute max, left glute max, and you should instantly see an improvement on the table. To be completely honest and transparent, there are many things that can influence table tests. You could have them sleep bad the night before and their table tests will be different noticeably. You could have them, you could have them just be in a good mood that day and it'll change it. There are a lot of things that influence these tests, and there's also a lot of things that can influence an individual test. Like you could tickle someone's feet and you might actually see that their straight leg raise gets better. I've seen it happen. But the thing is that not everything's going to get better. That's why I place such a large emphasis on make sure your intervention is successful. Multiple things are improving. Yeah, you could do something to improve your hip IR, but is your straight leg raise and your Obers also improving alongside with that? Yeah, your hip flexion might have gotten a little bit better, but is that hip abduction looking better too? And that femoral ER? This is where you really know you're having an effective intervention. If you didn't get a positive change, then either two things are possible. The first is that it wasn't coached well enough. And this is where a lot of issues can really start to come through, because you can have the exact right idea and the perfect plan written for this person. But if you can't coach the exercise well, then you could think that exercise doesn't work. And now you're going to spin your wheels for the next couple of weeks, maybe, because you actually did have the right intervention. You just couldn't coach it well, which is why execution is key and it is of the utmost importance. Or it just wasn't the right exercise for them. That's the other thing. But what I tell my clients is on the first day, like, hey, I've got an idea based off of your assessment results, what's going to work for you. We're going to try some things. Everyone's different. And I don't think I ever will be able to accurately predict exactly what exercises are going to do exactly what things to a person, because it depends on so many different factors. Nutrition, sleep, what do they do for a living? All these things, how familiar they are with an exercise. All these things can influence the success or lack of success in a given exercise. But I'm going to say, hey, we're going to try 3, 5, maybe even 6 different drills. I'm going to give you the 2, 3 that work the best for you. Some things will work, some things won't, but I have a general idea of where to go with you. And now it's just a process of finding the right things. If you're going to do an online assessment, this is generally the way that I would go. You can't really do Obers It's hard to do it. Hip abductions also really hard to do online. I don't love doing online stuff. I've kind of stopped doing it entirely myself because I'm busy, but also I just don't really have a passion for it whatsoever. But Trevor and Jacob both have a lot of online clients, and they are the people to talk to if you need some online help, because I'm just out of that space. We'll do stuff in the Zoom setting in review sessions, but if you have like individual client, like, hey, what do I do with this online client? Definitely ask them. If you need a quick assessment in person, like let's say you're a strength coach and you don't have the opportunity to run everyone through all 35 of your athletes through an entire assessment, then here are the things that I would do very quickly. Obers and hip abduction can be done like you're picking that leg up, bringing it back, boom, just take them into hip abduction after that. Shoulder abduction, trunk rotation. These are the big rocks anyway. These are the things I put weight in. We have an assessment sheet, and we're going to link it in the module for week 5 in the presentation, where we usually have links to stuff. It'll be there. You just go to file, make a copy on Google Docs, and you'll be able to use it for yourself, and you can adjust it however you want. You can highlight some areas that you want to work on. It's a nice little resource for you. So I understand that was a lot of assessments. Just as a sneak preview of next week, and I'm not going to answer any questions on this right now, but I do want you guys to get an appreciation for what's coming and why we have so many different assessments. This is the reason why. What we're going to do next week is we're going to be plotting all of these different assessments onto this sheet, and we're going to determine, where are you lateralized? Are you lateralized right, or are you lateralized to the left? And based off of that, we're going to be able to make our interventions highly specific to what they need. Bilaterally, yeah, it's good to know, but to be honest with you, I don't care all that much. I'm going to use it as a reference for how locked up they are on both sides, but the reason why they got locked up on both sides is because they can't effectively rotate from one side to the other. And this is going to be the most important resource we use in the course. That's coming next week. All of this is going to help us know where someone is in space. And all these assessments give us indications of their lateralization strategy of their thorax and their pelvis. All right. So hopefully that was really helpful. And again, if you want to post case studies, feel free. I'm going to give you the exact criteria of what I'm looking for, probably right after this call when I create the channel. And you can expect the rest of this course to be highly practical, especially in the review sessions. And just get really good at these assessments, get really good at knowing exactly when they're done. Look for those slight deviations. Any questions, Jade? Hang on, I think my speakers are doing something really weird. Can you speak, Jade?
Hi.
Okay, yeah, one sec. Well, try talking again, actually. Let me.
Okay, I guess I can just start with my question and that would.
Hang on one sec.
Okay, cool.
What in the world?
Testing.
Oh, you're good. I think just something odd is happening. Might be able to change where it's coming out of.
Yeah, go to your setting, speaker settings.
Can you try talking now?
Hello?
There we go.
Hello?
All right, hit me with it.
Good. Okay, so yeah, first I just want to say that was super helpful. All those tests, it was explained well, and it's really helpful. I do have a few questions. I think I can ask a few, and then if someone else wants to ask their questions, because I have 5.
Okay, hit me with 2 of them.
2 of them. Okay, all right. So for the seated femoral rotation, I was just wondering, is it okay to stabilize with your arms to keep posture? Like if you're on the table, like stabilizing with your hands, keeping them back to keep a good posture, or should we just relax our arms and maintain it ourselves?
I think you run the risk of creating a lot of tension as you do that. So if they can do that and not create any tension in their body, then that's cool.
Okay, yeah, because I noticed Trevor was back a bit on his hands, and yeah, okay,
That's
okay. Okay, all right. And then the next question is, why is the seated position different than the supine position for femoral rotation when it comes to ER? Because from the way I see it is that the 90 degrees hip flexion is the same whether they're seated or supine.
Let me show you a slide from week 2.
Okay.
Okay, we know that 90 degrees of hip flexion is an IR position, yeah?
Yep.
However, we go all the way down here. If you have one leg in extension and one leg in flexion, this applies more when it's active. It's not active, but it still matters. You are turning the pelvis more so towards the upside, which is biasing the ER. Relatively more than being in a seated 90-90.
Okay, so if they're both in the 90 degrees, then it is more IR, but then when it's one or the other. Okay, all right. That makes sense. Okay, thank you. Cool.
Tiffany?
Yes, hi. I am curious about hip distance apart in terms of stance. I actually had, yeah, I always line people up basically like here. I just went to a Rolfer and he was insisting that it needs to be basically like the PSI or not the PSIs, the cyst bones. He's lining people up with the cyst bones and
For what?
so when you say hip distance apart,
Okay, so you're saying that he's saying hip distance entails in line with the
cyst bones.
sit bones. Okay, gotcha.
Yeah. And yeah, my kind of understanding is it's, like, can you see me? Oh, there we go. Okay, I moved. It's like, yeah, like here, right? Knees, yeah, right there versus if you look at my feet,
Mm-hmm.
like he's kind of like saying here, which is here.
Yeah, I mean, maybe,
Yeah.
maybe depending on their hip morphology, but I question how well you're going to be able to express like a squat in that position. Like if you have someone go that narrow and try and squat on day one, like 90%, 95% of people aren't going to be able to get past like 70 degrees. You know what I mean?
Yeah. Yeah, like I can see how that could be kind of useful, like in terms of like tripod foot and that kind of stuff.
Mhm.
But yeah, like, but yeah, he's like, I can stand there all day, and but, you know, yeah, there's also, women and men have different widths, right? Like slightly. Yeah. So when you say hip distance, so like for a squat assessment, more here,
Yeah.
right? Like that's what okay. I just wanted to make sure.
It's like he may be right for some people, but I want to put someone in a position where they can express relative motion and require it to a high extent, but not so much to where it's unrealistic.
Yeah. Yep. Okay. That's what I thought. Thank you.
No problem. Logan?
All right. So you talked a lot about how like when you should end a test, obviously. But what about if we're looking at like protective tension? So I know a lot of times my younger athletes or people who have more mobility tend to get like these like muscle twitches. Like, is that a reason to stop, or is it more like, okay, let's just take you through this again, get you to be more relaxed and see if we can really complete an end range?
More so the latter. Yeah. If you feel like something's off, just take it again and then maybe take it again. So that way you know that you're consistent.
And if you do find that, and this is what I tend to do, is like, is that usually pointing towards a lack of stability through that full range?
Maybe. I think it'd be hard to pin it down exactly as one thing, but maybe.
I tend to double check a lot with active versus passive, and every time I see protective tension, they are like half the range of motion actively, if that. So it seems to be a lack of control on some of it. But and then my other question, I work with like 95% baseball players. So obviously a different population than general fitness. Not a ton of people who are in pain like you deal with, but you gave a lot of kind of goal ranges of motion. Would these change for these types of overhead athletes, these different populations? I know obviously you work with baseball players as well. Like we're going to have a lot of external rotations versus internal rotation. And are there different guidelines? And if you have those, it'd be awesome to hear them.
Very good question. So the difference is like between what you're describing, what I'm describing is this is like under normal human circumstances and conditions, this is relative motion being expressed. But when you have an athlete or you have someone that's older or younger, they're obviously going to have to be expectations that are tailored towards that individual. So for a 85-year-old person, am I going to really expect them to have full knee to chest hip flexion? Like, no. And that's why the improvements are also relative. So for a big jacked bodybuilder guy who has huge legs, is he ever going to get full knee to chest? No, but maybe taking him from 100 to 115 degrees of hip flexion is really meaningful for him. So same thing for your athletes. Like I would find where they're at, and we're going to get more into this as the course progresses. As you work with someone more and more one-on-one, you gather data on them and you know that like, okay, I know that my elbow is going to flare up when my shoulder internal rotation is less than like 40 degrees. But when it's not, then I feel pretty good. So you have a proxy for understanding where that person's at. So that would be my best advice for you.
Okay. Yeah, that makes perfect sense. And then just the last one, you don't even have to answer it. Maybe it's what we'll talk about more. I deal with a lot of asymmetries with a lot of guys, obviously being one-sided rotators, swinging and throwing from the same side. But I assume sometimes this can be beneficial and sometimes we don't want to get them out of their asymmetries because sometimes it can actually be a little bit of their superpower in being able to rotate that way. And I'm sure we'll talk about it more, but just something I've thought of a lot is like, when is the right time to help balance this guy? When is not the right time to help balance? I assume a lot of it is like if injuries come up, stuff like that.
That's a good question. I used to think, and I don't know if I've said this yet, but I used to think that I would be making such a meaningful change to this person and giving them so much more range of motion that it's like, oh, I don't even know what to do with this anymore. Like I might not have stability through this range, but I found that that's almost never been the case, unless the exception being hypermobility. Those are the only people I've ever worked with where it's like, oh, I actually feel a little bit more unstable now. But when you have an athlete or someone who knows how to use their body, even like a regular person, these relative motions, I think the body intuitively knows how to utilize them because we're designed to use them. So usually when you restore motion, it's not like they don't know what to do with it. It's just like, oh, I already have my patterns. I already have my motor skill. Now I just can do this with a little bit more freedom. And so that's what I usually find is like, I felt a little bit easier and more fluid on the court today, or I felt like my arm didn't hurt as much afterwards and I had a little bit more range to do the things I wanted to do anyway. That's what I find. I just haven't run into a lot of situations where it's like I don't know what to do anymore.
Okay. Yeah, that makes perfect sense. Appreciate it. Thank you.
No problem. Gaetano? Am I saying that right?
Gaetano, yes.
Okay, cool.
Hi. I have two questions. First, in the squat test, how important, how relevant is the ankle dorsiflexion in the squat test? And do you even test for tibia internal rotation and external rotation? And is it important?
They are important. And we talk about the lower limb and the lower limb and foot course. It's just too much. Like at some point I have so many assessments where it's like, it's too much to think about. So we try to reduce that in this course. But yes, tibial internal, external rotation are things that we consider, especially when those issues are present at the lower limb. But if we look back at the week 2 slides, let me pull them up very quickly. Dorsiflexion is maximized actually in this sort of 90 to 100 degree zone. Beyond that, you actually need less. So good squatters with generally normal limb lengths will have the knees move slightly back in the bottom position of a squat because they don't need more dorsiflexion. They're moving relatively more towards ER. So dorsiflexion can be a limiter up into that 90 to 100 degree range. And you can work on adding more, which is why people can actually squat deeper when they, you know, let's say they get hung up at 100 degrees, but they work on their dorsiflexion and they get deeper. That's because they've improved their dorsiflexion to the point where they can use their orientation-based strategy to still get deeper into the squat, but they still might not be able to fully counter nutate and externally rotate. So it's a strategy to get deeper, but if we're talking like true relative motions of the hip, then working on your counter nutation deep hip ER would be the way that you can truly get that back.
Okay. Okay, thank you.
Which is why some people can look very extended in their low back at the bottom portion of a squat because they are moving through other things.
Okay, thank you.
All right, let's go, Yanina.
Hi. So 2 questions. One is when you were doing the hip flexion, you mentioned that you stop the test if you feel a hip flexor pinch. How do you like? I know the person would feel it, but how do you feel it? I've never done this, so like maybe when I do it, I'll know. But how do you feel the hip flexor pinch?
You'll feel it. It feels like you're hitting a block.
Oh yeah. Okay.
It just feels like you're running into something, just general tension. And it's hard to describe unless you're there, but there's a difference usually between a muscular block and a bony block end feel. And the more you work with it and the more you differentiate between like, okay, is this in the superficial part of your hip or the deep part of your hip? Then you would know like, okay, this is your hip flexor. I'm going to get a feel for what this is. Then it's like, oh, it's an impingement-like sensation. Get a feel for what that is. And you'll figure it out pretty easily.
Okay, thank you. Other question I have is, I'm going to try my best to phrase it. When you were doing the straight leg raise with Trevor, you mentioned like that he's tight, and that you mentioned that oh, did you do legs yesterday? And which made me think that if his joints are in the right position, regardless of how his muscles are, would he get the same straight leg raise? Or I guess, or does the, like, I know muscles matter, right? But for some reason I was thinking like, as long as your joints are in the right position, you would be able to get to 90 degrees. But if you have exercise and if you're tired, does that, like, that can also influence it? So I kind of got like, or is like a gray area. So
yeah, if you did a really heavy leg day, then that is obviously going to create a lot of compression, a lot of inflammation. So that can limit and alter these tests, which is why it's good to check in with that kind of a thing. But that being said, you can still make changes from that position, but it's just good to know what they did the day before if they're presenting differently than usual.
okay, so if you see like a test is lower, let's say you're working with somebody and then you notice that their straight leg has got worse, so it's good to check with them, what did you do yesterday? And then they say they did their leg day or something like that, then you're like, okay, then that makes sense, as opposed to thinking that something is off and, you know, like you're kind of going backwards from where you started from.
Yeah, this is something that's kind of built into the progression model. As you'll see, like in order to progress someone, their assessments need to look a certain way and they need to hold on to those adaptations. And if they're not, then there's questions you ask, like how are you sleeping? How's your stress? Stuff like that. And that's going to allow you to get an understanding if those things are blocking their ability to progress.
Okay. All right. Thank you.
Kurt?
Hey, Connor. Got a couple of questions. Would you be able to, I'm struggling to visualize when someone's stuck in the left AIC, they're supposed to have more IR on the right femur, right? On the right hip. Yeah, I'm struggling to visualize why that would be.
Why is that hard to visualize for you?
Like on the skeleton. Because if you turn to the right, wouldn't you expect to see better ER? Like in my head, because you turn away from IR and you turn toward ER. So
Yes.
you're turning to the right hip.
Yeah.
So
remember that principle applies in dynamic environments. When we're talking about this, the left AIC pattern and posture and all that good stuff, this is a static representation of that. And also, this is relative motion. So in the left AIC, you are nutated and the nominate bone is IR'd and you're shifted over and up on that side like that. So you are in the pattern, you're like that. Think about it more like this rather than this. You do have that component, but you are mostly just lateralized over to the right side. So because of that, the femur is going to go in, and that's going to block your ability to move into ER. You're not going to be able to get that because the femur is so adducted relative to the left side. You're not going to be able to get that.
Is it just the adductors restricting that movement, or is it like a bony restriction? Or
it's everything. That's the thing. It's your whole pattern. It's your anterior chest wall compression. It's your lack of ability to turn your sternum away from that. It's your posterior, or sorry, your anterior glute med. It's your hamstring. It's so many things. So that's why, like, you got to take everything into account, because in order to get someone to improve hip IR, it's like you got to be able to effectively get them to either shift in or out of that side better. For IR, it'd be like, can you load that side? And can you get mid stance and represent that on that side? For ER, it's can you get potentially early or late stance?
so in this case, it's more of like soft tissue restriction rather than when you have an anterior tilt, then that's more the bony restriction preventing you from getting.
I think it's both.
Yeah.
I think the tissues are the way they are because of the position of the joints, and that's because of your lateralization strategy. So that's that brain, joints, muscles principle. I know it's a hard thing to shift our perspective on, because it's like, well, what muscles are blocking me from doing this? But the muscles are the third layer of why you're doing the thing you're doing, why you're limited in that, because you're first and foremost lateralized towards one side. When you're lateralized towards a side, that's going to put your bones in a position. And then if you stay there, your tissues are just going to eventually get used to being in that position.
All right. So then when you move from standing to being in like an assessment situation, sitting down, those muscles are still concentric.
Yes.
Blocking you from getting into ER. Okay.
Mm-hmm.
Yeah, one more thing is, why do the heels come up in a squat if you're lacking ER, sorry, or whatever?
The heels come up because it allows you to orient more effectively. So like anything that's a deviation from what you would expect to see is usually an orientation-based strategy. In order for you to genuinely get to the bottom portion of a squat, you need to be able to load your heels, which represents ER counter nutation. That's heel strike, right? ER counter nutation, heel reference. But when you come up, you're either A, probably lacking that dorsiflexion component, and B, that allows you to find some degree of ER, but it also allows you to posteriorly orient as well. It allows you to just dump under, and that allows you to move through your lumbar spine more effectively. If you get up and try it, you'll see what I mean.
Yeah, is that because you're shifting your weight forward onto your toes?
Yes, which allows you to dump your pelvis under you.
Okay, yeah, I'll test that out. Thanks.
Mm-hmm. Kate.
Hi, is that me? I just wondered, can you hear me?
Yeah.
Oh, I just wondered if you could show the trunk rotation measurement again. I'm familiar with all the other tests, but my daughter walked in and distracted where you were talking about the crease in the trousers of the measurements in the shorts. And I just wanted to be clear on that, where you were taking the measurement from, if that's okay.
Yeah, it's hard for you as an individual to take it properly. And the thing is, like, when we take these assessments, I want you guys to understand, important point here, that we're concerned with getting generally consistent results, but the side-to-side differences matter more. They do. And if you generally know what a 45-degree angle is and a 90-degree angle, then like you can find in between. And if you measure trunk rotation and for you, like 70 degrees is what you call it, but in reality, it's actually 60 degrees, then every time you see 70 degrees, you're going to call it 60 degrees. and you're consistent
okay.
wrong, but it doesn't
Right,
matter
okay.
because you're consistent. You see what I'm saying? So Jacob, if you
Yeah,
right
yeah,
here,
yeah,
most
that
Jacob,
makes
we haven't
sense.
seen him yet.
Yeah. Okay, thank you.
I honestly
helpful.
like, don't really take, I encourage you guys to take angles initially because you will get an appreciation for what angles are what, but I've been taking angles for so long that in my mind, I
Yeah.
know what it is in
Yeah.
my system. So let's go.
Yeah, I used to use one, but I tend to just eyeball it now to get a feel for it. But I was just wondering how accurate you do measure them.
For sure. Yeah. Well, we haven't seen Jacob yet, so we'll see where he's at. Which is yeah. Hang out there. These
Yeah.
together. Starting at 0. Right there. You can start to see that arm start to come with. You see that? So in my mind, I look at this. It's so hard to see because you're at the side, but if I'm looking right there, I'd say this is about maybe 50-ish, 55 degrees. Go to the other side.
Yeah, I can see that. Yeah.
Degrees. Right.
See that?
Yeah. Right there. This is easier.
Yes. Yeah.
So it feels easier. I'd call that around like 65, 70, probably 65.
Right. Okay.
So you see what I'm getting at there?
Yeah.
There are
Cool.
tools on the internet and apps where you can draw little angles and it'll tell you what angle it is. So my best recommendation for that is find an app. I'm actually out of touch with what apps are out there now with this because I don't really do it too much. Take a screenshot of where they're done and then draw the angle and you'll be able to see.
Oh, okay. Yeah, I've used Coach's eye before with runners, so I've marked it that way. Yeah,
give it a shot.
Tool, I guess. The other question I had is on the squat. When you were doing the test, do you stop them at all if they flex forward too much, as well, or not? Because
if they
how much would you say? If they do you stop it straight up? Because some people lean, or do you allow them to bring their arms forward to counterbalance, or do you just stop it?
Good question. I'm cool with the hands forward, but
okay.
The reason why there's no hard and fast like much hinge is because it's so different for everyone.
Yeah.
I would really struggle to tell you exactly what it is, but generally speaking, like if they start in a certain orientation straight up and they go down, they go down, they go down, and they're a little inclined, like whatever. But once you see that happen, that would be the end of the test. But also once that happens, they're going to butt wink very shortly after.
Sure. Because before I've always sort of looked at the angle of the chest being the same as the shin angle. And if it goes beyond that, I've stopped it. I've used that. So I don't know what your thoughts were.
I'm cool with that.
Helpful. Thank you. Okay,
cool
brilliant. Thank you.
Yeah.
Thank you.
We have time for one more, guys, and then we got to go because we have a lot to do this afternoon. Let's go. I think Carlos, I think you had your hand up. Go ahead.
Okay, it'll be real quick. First question, how often do you think we should test our trainees or athletes?
I promise you that's coming soon. So don't worry about it right now. Just get reps.
Cool.
Shauna?
Okay, and sorry.
Go ahead.
Just a second question. Real quick, sorry. Okay, so I'm starting or assuming the fact that maybe some people will never reach relative motion. Okay, so for example, if one trainee comes to us, right, and this guy is in a really bad position, his runs are awful, right? So if we manage to improve the run this person through orientation, would we consider that a victory or not really, or what would apply in that case?
Very good question. This is an exact example of someone who will get better on one test, but not on other tests. So their straight leg raise may improve, but that hip IR, that Obers, and that's how you know it was an orientation driven change versus relative motion. That was a perfect question to end on. So I hope everyone internalized that. All right. Thank you guys for coming. Thanks for being flexible with the schedule. I will see you tomorrow, 10 a.m. Pacific Standard Time. Be there because it is such an important review session. I will see you guys later. Appreciate you guys.